Good morning, dear students. So today we'll talk about one of the most important methods of examination of the heart patient. We'll talk about auscultation. We'll talk about auscultation. So, auscultation. Before we start talking about auscultation, let's remember anatomy of the heart. Anatomy of the heart. Of course, you know that our heart has four chambers. We have two ventricles, left ventricle, right ventricle, and we have two atriums, left atrium and right atrium. Between these chambers, we have valves. Valves, this is like doors. Valves let blood flow only one way. So between left atrium and right and left ventricle, we have mitral valve. Between right atrium and right ventricle, we have tricuspid valve. These valves are also known as AV valves, atrioventricular valves, AV valves, mitral and tricuspid. Also, we have two valves, one in aorta. This is known as semilunar valves, semilunar valves. So we have aortic valve and pulmonary valve, aortic valve and pulmonary valve. Actually, to understand which sounds, why appear and which sounds and why they appear in the heart, you should understand how the heart works. So if you will be able to have in your mind the picture of the working heart, you will easily answer all questions about auscultation. So again, let's remember anatomy physiology. So what we have? We have heart is a pump. The pump should pump blood. We have two circles, big circle and small circle. The big circle starts in left ventricle, then blood goes to aorta, then reach all faraway parts of our body, and then collect it into right atrium. Then blood enter right ventricle and inject it into small circle, pulmonary artery, pass through lungs and return to the heart to the left atrium, This is two circles of the heart, two circles of circulation, big and small. Next, what you should realize, what you should know. Again, to understand auscultation, you should know direction of blood flow and position of valves closed or open in each phase of heart activity. If you know this, which is blood flow direction and what is position of valves closed and or open, you can easily explain all auscultatory phenomena. What happened in the heart, what produced noise in the heart. So, of course, you know that we have two phases in the heart activity, diastole and systole. Diastole, also known as filling. Again, heart is a pump. This pump should be filled and then pump eject. First, blood fill our heart and then our heart eject the blood. So, what happened in diastole? Also known as period of filling. In diastole, what is the direction of blood flow? From atriums to ventricles. Left atrium to left ventricle, right atrium to right ventricle. We have filling of ventricles. You may ask, what force blood to fill ventricles? Because it's diastole. You know that in diastole, heart relaxed. Nothing can create pressure. That's why we have blood flow. What force blood to flow from atriums to ventricles? You know that during systole, when blood injected into vessels, into arteries. And all these vessels, they have some elastic properties. Now just imagine, if you feel some actually balloon with air, you blow into this balloon and balloon enlarged, yeah? And then if you stop even blowing, balloon can create some pressure. The rubber in balloon create pressure. And that's why if you open balloon, air go out. The same happened in our cardiovascular system. When heart during systole create pressure, our vessels stretched, as a result, they then press the heart, creating pressure. That's why we have systolic pressure and diastolic pressure. The systolic pressure due to heart activity, diastolic pressure due to elastic properties of our vessels. So now we know what force blood to flow from atriums to ventricles. Position of valves. You know that valves may be in two positions, closed or open. Again, like a door. Door may be open, may be closed. What is the position of valves? No easier, it's easy to understand. If actually blood flow from atriums to ventricles, it means that AV valves open. During diastole, AV valves open. What happened with semilunar valves, aortic and pulmonary? Closed. Because again, valve let blood move or flow only one side. For example, it let blood, AV valves let blood flow only from atriums to ventricles. But if blood tried to go out, to go retrogradely, to return back, valves immediately closed. Semilunar valves let blood also flow one way from ventricles to vessels, to aorta and pulmonary trunk. In diastole, blood tried to return because in diastole we have pressure in aorta and pulmonary trunk, but cannot because AV valves closed. Again, diastole, semilunar valves closed. Diastole, AV valves open and blood fill ventricles, semilunar valves closed. What happened in systole? Systole or pumping or ejection. During systole, we have contraction of ventricles, and what happened? Blood go out from ventricles to aorta and to pulmonary trunk, to pulmonary artery, to aorta and pulmonary artery. Position of valves, semilunar valves, aorta and pulmonary open, AV valves closed. AV valves closed. AV valves can't let blood return to atriums. So this is picture what you should have in your mind to understand what happened in the heart. What produced sounds, what sounds produced and why. Now again, this is valves. What I try to show you. This is valves. When blood move this way, these cusps of valves, as we call cusps of valves, open. If blood try to go back, this blood flow close these cusps, close cusps and cusp closed. This is section of the heart, and we can see all valves, all valves. If you see from the top, from this top down, we can see mitral bicuspid valve on the right side, tricuspid valve, precusps, RA 1, 2, 3, and two semilunar valves. Deeper, we have aortic valve, and outside we have pulmonic valve. Okay, actually, cardiac cycle more complicated, and I'm telling more precisely about what happened with heart activity in each phase of the heart. Again, we can start from diastole. During diastole, again, we have filling, AV valves open and blood fill ventricles. Semilunar valves closed. What happened then? At the end of diastole, we have contraction, period of contraction. You know that we have sinus node, which produce electrical impulses, and electrical impulses force cardiomyocytes to contract. Heart is a muscle. But contraction starts from atriums because sinus node placed in atrium. So when we have contraction, first we have contraction of atriums. And as a result, at the end of diastole, we have contraction of atriums, and blood from atriums, the remaining part of blood from atriums enter ventricles. Now this is so-called active filling. Active, why? Because we have contraction of atriums. contraction of atriums, and we have active filling of ventricles. What happened then? Then impulse from sinus node reach ventricles, and ventricles start contracting. Contracting, they increase pressure in ventricles. They increase pressure in ventricles. What happened? Due to pressure, blood tried to return through open AV valves back to atriums, but AV valves never let do this. AV valves immediately closed. If AV valves closed, we have so-called period of 4 closed valves, or period of isovolumic contraction. Isovolumic contraction. Why it's called so? Because now all valves closed. AV valves already closed, actually semilunar valves still closed. Pressure rise, but you know it's impossible to compress water. That's why volume remain the same, pressure rise. That's why we talk about isovolumic, iso equal volume contraction. What happened then? Then pressure in ventricles becomes higher than pressure in big vessels, in aorta and pulmonary trunk. When pressure in atrium in ventricles becomes higher than in aorta and pulmonary trunk, this pressure open semilunar valves, and we have ejection. We have period of ejection. Blood ejected from left ventricle to aorta, from right ventricle to pulmonary trunk. Position of valves again. Semilunar valves open, AV valves closed. Then we have beginning of diastole, period of isovolumic relaxation. Period of isovolumic relaxation. Meaning what? When pressure in ventricles decrease because no contraction, this pressure which was created in aorta and pulmonary trunk, diastolic pressure, force blood to return because pressure in aorta and pulmonary system now higher than pressure in left or right ventricle. But we have valves, and these valves don't let blood to return. At the result, semilunar valves closed, AV valves still closed, and we have period of isovolumic relaxation. Period of isovolumic relaxation. What happened then? Then finally, pressure in atriums becomes higher than pressure in ventricles. I told you already about this. And this pressure force AV valves open. As the result, blood from atriums again fill ventricles, and we have period of filling. And again, it's repeated millions of times. Repeated millions of times. So again, I think that all of you already have stethoscopes, and if you apply these stethoscopes to your own heart or to your neighbor heart, you will hear, of course, some sounds. We will hear sounds. Usually, we can hear something like this. We have two sounds, two knocks, two heart sounds. What creates this sound? You know that sound means vibration of something. What creates sounds? Sounds transmitted, this is acoustic waves transmitted through air or with air and reach our ears. And to create sounds, you should vibrate, cause vibration of something. You know that we can hear vibrations from 20 to 20,000 hertz or vibrations per second. That's why if we hear something, means that something vibrates in the heart. Something vibrates in the heart. What can vibrate in the heart? What can cause vibration in the heart? Valves. You know, mostly we can hear valves. And what we can hear, you see valves maybe in two positions, open and closed. And all the time, valves open, closed, open, closed. What is more audible? What is more audible, opening or closure of heart valves? Now you can do this experiment. Come in your room, open door, and then close the door. What you can hear? Of course, you can hear when door closed, because when door closed, door beat the wall, create vibrations, and as the result, we hear sounds. We hear some sounds. The same happens in the heart. When heart valves closed with high velocity, with higher force, they cause heavy vibrations, and we can hear these vibrations as a sounds, That's why normally only the closing of the heart valves can be heard. So question, we have 4 valves. But normally we can hear only two sounds. How it's possible? 4 valves, 2 sounds. It's possible because third valves, AV valves and semilunar valves, they close simultaneously at the same time. And that's why closure of atrioventricular valves, tricuspid and mitral, produce the first heart sound. We call this S1, the first heart sound. This is closure of 2 valves. Now this is like this. If we have some 2 sounds, 1, 2, you can hear this differently. But if I beat my desk at the same time, even with 2 fingers, you can hear only one noise, only one sound. The same happened in the heart. Because tricuspid and mitral valve closed at the same time, you can hear instead of 2 sounds, you can hear only one sound. And then semilunar valves also closed at the same time, and aortic and pulmonary valves produce second heart sound, S2. And the result we have, usually we can hear 2 heart sounds, S1 and S2, and we can hear something like this. You see, this is a lot of characters. This is just sequence of the opening and closing of the 4 valves. You see that first, at the beginning of systole, mitral valve closed and then tricuspid valve closed, then pulmonary open, aortic open, then aortic closed, pulmonary closed, then tricuspid open, mitral valve open. Why it's red? Because this is closure. Only closure of these valves we can hear as sounds. And again, as mitral and tricuspid valve close simultaneously, we have first sound. Then AV, then actually aortic and pulmonary closed at the same time, and we can hear second heart sound. Now you can say, for example, lab-dub, lab-dub, lab-dub. The lab, this is closure of atrioventricular valves at the beginning of systole, and dub, this is closure of semilunar valves at the beginning of diastole. That's why, by the way, first heart sound, also known as systolic sound, and second heart sound known as diastolic sound. The diastolic sound. So again, we have 2 components. S1 has 2 components. M1, this is closure of mitral valve, and T1, this is closure of tricuspid valve. Now again, the same picture where this happened. This happened at the beginning of systole, when you see, when we have closure of AV valves, when ventricles contract, and this produces first heart sound. Okay, I explained to you these periods of normal heart activity, But, you know, in medicine, all the time we have some exceptions. And sometimes instead of 2 heart sounds, you can find actually 3 heart sounds, something like this. You can hear some additional sound. Actually, there are 4 sounds, but usually only 2 sounds audible. But in some cases, this 3rd and 4th heart sound becomes audible, and we can hear this as additional sounds. So S3, at the end of rapid filling period, 3rd heart sound may be heard. S3 occurs 120, 1 second, 170 milliseconds after S2. And this period approximately the same time as to say me too, then me too. First sound and then second sound and then additional sound. Me too, me too, me too. So very close. Me S2, me S2, 2 is S3. S3 is normal in children and young adults. When it presents in individuals older than 30 years of age, it signifies a volume overload to the ventricle. No regurgitant valvular lesions, congestive heart failure may be responsible. Now, if to draw this, we can draw these sounds. For example, this first sound, no, first sound consists of two again, mitral and tricuspid, and S2 consists of aortic and pulmonary. And normally this is very small, inaudible S3. But in case of enlargement of this S3, it becomes audible. Well, you can ask, what vibrates? What vibrates? If we can hear something, it means that something vibrates. Vibrate is following. When this S3 happens, during diastole. What we have during diastole? We have feeling. When blood from atriums with high velocity enter ventricles. And this blood flow can beat the wall of the ventricle, beat the wall of the ventricle. If we beat something, this something may start vibrating. And it's understandable, I told you, when overload with volume, when bigger volume of blood than normal from atriums fill ventricle. If bigger volume of blood fill ventricle, this big volume beat the wall of the ventricle vibrate and create sounds, and we can hear this sound as S3, the audible S3. Again, in young adults and children may be normal. In elder people, tell us about overload with volume. Overload is volume. Too much blood enter ventricle. S4 happened at the end of diastole. You know, mechanism is dissimilar. Remember, what happened at the end of diastole? At the end of diastole, we have contraction of atriums, and the remaining part of the blood, again, enter ventricle. And again, velocity of blood flow increase. Blood with high velocity beat, again, ventricles. Again, it may produce some vibrations and sounds. That's why S4 happened just in front of S1, just teeny seconds before S1. Again, you can say middle, me, this is S4, do, this is S1. So it's happened just before S1. Again, normal in children, young adults, but if it's happened in individuals older than 30 years of age, no, this is non-compliant, so-called stiff ventricle. No, again, we'll explain you what does it mean, stiff ventricle. When ventricle enlarged due to actually hypertrophy, when in ventricle we have more collagen fibers, ventricle becomes hard, non-compliant, stiff, and easily vibrate when blood flow beats the wall of the ventricle. Usually this is result of hypertrophy in case of, for example, coronary heart disease. Again, on the picture, this is S1, S2. S4 happened just before S1. And again, normally it's inaudible, we can't hear. When it becomes bigger, higher amplitude, we can hear this. And we talk about audible S4. Again, S3 happened here after S2. S4 happened just before S1. So presence of S3 and S4 creates cadence resembling the gallop of a horse. And these sounds called gallop sounds. No, I try to show something like this. You can hear that actually resembling the gallop of a horse. The gallop of the horse, that's why it's known as gallop sounds or gallop rhythm. Again, in children, it may be physiological. In elder people, this is pathology. You find this, search what have happened. Okay, next story. Sometimes we can hear something more than two sounds, not due to gallop rhythm, but due to so-called splitting mechanism. Idea of splitting is very simple. Remember I told you that normally two valves, AV valves, mitral, tricuspid, close simultaneously. We can hear one sound. And then two valves, aortic and pulmonary, close simultaneously. And we can hear one sound. But just imagine what happens if for some reason these valves, for example, mitral and tricuspid, closed not simultaneously, but with a little difference in time. In this case, instead of one sound, we can hear two sounds. And this is known as physiological, as splitting of sounds. So it may be splitting of S2, it may be splitting of S1. It may be splitting of S2, splitting of S1. Now, there are different possible causes of splitting. In some cases, this is physiological. In some cases, this is pathological. Now, let's try to explain why it may happen. For example, we have A2, P2. We have aortic component of second heart sound, and we have pulmonary component of second heart sound. A2 normally precedes P2. So usually, remember this long line of characters. First, we have closure of aortic valve, then we have closure of pulmonary valve. First aortic, then pulmonary. But again, distance is very small, and we can't understand that this is two sounds. But try to do one simple experiment. Examine yourself, put phanydoscope under your heart, and make deep inspiration. Create deep inspiration. Suddenly, you will find that you have splitting of sounds. Why it may happen? With inspiration, intrathoracic pressure lowers. This causes more blood to be drawn from superior and inferior vein cava into the right heart, because low pressure in the chest sucks blood into the heart. What happened then? Right ventricle accepts more blood, right ventricle enlarges, and for right ventricle, it takes just longer time to eject this blood into pulmonary artery. As a result, we'll have some delay in closure of closure of P2. Normally, again, A2 precedes P2. But actually, if we have even some enlargement of this distance because of delay of closure of pulmonic valve, we can find this as a splitting. We can find something like this. Again, second sound split. Instead of one sound, we have two sounds. And in this case, we talk about physiological splitting, because if you breathe out, this phenomenon disappear. This splitting disappear. Now, try to show pictures again. This is actually S1, S2. This is normal. What happened then? If you inspirate, this pulmonic component move out from aortic component, some delay in closure. This delay in closure we can hear as actually splitting of S2, Sometimes it may be pathological splitting, for example, due to right bundle block, right His bundle block. You know that we have His bundle in our heart. This is actually conductor for electrical impulses, which reach left and right ventricle. We have right His bundle and left. And what may happen? Due to some pathological processes, atherosclerosis or something like this, one of these branches, the left branch or right branch, may be blocked. What happened in the blockage of right branch of His bundle? Impulses first reach left ventricle, because what for we need this His bundle? For rapid delivery of impulses, for rapid passage of impulses. If one bundle blocked, damaged, it does mean that right ventricle never contract. Patient die in this case. But fortunately, we have Purkinje fibers, we have some bypasses, and electrical impulses reach right ventricle. But it's happened later. It's happened a little bit later. As a result, first we have contraction of, as usual, left ventricle, and then right ventricle. And then again, we have some delay, and this delay we can hear as actually the splitting of heart sound, Okay, next, now we know what we can hear in the heart. Now we should discuss how we can hear this. We should talk about technique of examination of the heart. No, you know that actually in phanendoscope, usually we have bell and diaphragm, the bell and diaphragm. No, it's considered that some high-pitched sounds like wave closure or heart sounds, regurgitant murmurs better heard with diaphragm. Low-pitched sounds, gallop rhythm, murmur of atrioventricular stenosis better heard with the bell. But don't worry, if you have diaphragms from both sides, don't worry, sounds will be the same intensity. Now what else? Never listen through any type of closing. Is usually, you know, in movies, doctor examine patient and just apply phanendoscope to his t-shirt. Of course, it's impossible. Never listen through any type of closing. No, this is also not a good way how to examine patient. Again, where we should apply our phanendoscope? Where we should apply our phanendoscope? We have 4 classical auscultatory areas correspond to points over the precardium at which events originating at each valves are best heard. So again, understand one simple thing. All heart sounds usually created in valves. The valves, this is creator of heart sounds. That's why if we have 4 sounds, we should have 4 points to examine each sound. We should find point where each valve audible the best, where this is the best point for auscultation of one or another valve. And this area is not necessarily related to anatomic position of valves, because anatomically all valves placed nearby. But fortunately, we have specific points where each valve better heard, where each valve better heard. So now if to remember anatomy, you see all valves placed nearby. And this is mitral valve, tricuspid valve, aortic valve, and pulmonic valve. But again, what happened? That, for example, for mitral valve, best point of examination, not here, but here on the apex of the heart. For tricuspid valve, best point of the examination is sternum, middle of sternum. And for aortic valve, best place, this is second intercostal space on the right from sternum. And actually for pulmonic, more or less the same place as the position, the second intercostal space on the left from sternum. So again, auscultatory areas. Let's show this picture. Again, mitral area, where we can examine mitral valve. This is fifth intercostal space and 1-2 centimeters medially from mid-clavicle line. Aortic area, second intercostal space, right sternum body. Pulmonic area, second intercostal space, left sternal body. And tricuspid area, no, this is somewhere between sternum and manubrium and actually processus kyphosopus of sternum, somewhere here. Now again, mitral cardiac apex, aortic second intercostal space, right sternal body, pulmonic second intercostal space, left sternal body, and tricuspid, left lower sternal body. We have one more additional point. Between mitral and aortic area, we have so-called Erb's point somewhere here, because we need this point, some regurgitant murmurs better heard here if we have damage of aortic area, of aortic valve. We also even give names for each area. We name this by numbers. Mitral area first point, mitral first point, aortic second, pulmonic third, and tricuspid fourth. And we ask you to follow this sequence. Again, we start from mitral area first point, then aortic second point, then pulmonic third point, and then tricuspid fourth point. 1, 2, 3, 4. 1, 2, 3, 4. What is the position or posture for auscultation? What about posture for auscultation? Actually, there are 4 postures. First of all, just supine position, supine position. Then left lateral decubitus position. Patient just in lying position, move to his left side. Move to his left side. Then we have upright position, the upright position, and we have upright leaning forward. Upright leaning forward. What for we need different positions? Because you know sometimes some sounds better heard in one or another position. Some sounds better heard in one or another position. So all precardial areas examined while patient is supine. After all areas examined, the patient is then instructed to turn onto the left side. The examiner should now listen the apex for the low-pitch diastolic murmurs of mitral stenosis, which the best heard with the bell of the stethoscope. No, this is details. For example, on the left side, yeah, we can find mitral stenosis murmurs. No, I'll explain later what does it mean. Yeah. No, then sit upright, examine all areas with diaphragm of stethoscope. No, and patient asked to sit and lean forward and actually hold breath on exhale. In some cases, for example, aortic regurgitation better heard in such position. Так, influence of breathing. Examiner should pay special attention to the influence of breathing on the intensity of the heart sounds. Most murmurs or sounds originating in the right heart will be accentuated or increased with inspiration. So if something happened on the right side, patient inhale, sounds becomes more audible. No, this why happened. Again, I try to explain, related to the increased return of blood that occurs with inspiration and resultant increased right ventricular output. So when we breathe in, more blood return to the right ventricle, and that's why if something wrong with the right ventricle, it's create more sounds. Next. Okay, you can hear two sounds. First question you should answer, where is first sound? Where is second sound? Now, where is first sound, where is second? Because later we'll talk about increase intensity of first sound, decrease intensity of second sound. But to understand where is first and where is second sound, how to differentiate, there are a few approaches. The simplest one, you know, if heart rate is normal, usually in this case, diastole is much longer than systole. And you can hear something like this. You see two sounds with short pulse and then long pulse. Long pulse, this is diastole. It means that sound which appear after long distance, this is first heart sound. After short distance, this is second heart sound. Clear? First, second, pause. Sound after long pause, this is first. Sound after short pause, this is second. But in some cases, when sounds accelerated, it may happen something like this. Different to say, where is systole, where is diastole? In this case, we can do what? We can examine patient, but at the same time, place our fingers on carotid artery. And sound which corresponds pulsation of carotid artery, this is first heart sound. Yeah? Left hand placed on the patient's carotid artery, and the sound that precedes the carotid pulse is S1. S1, this is sound which precedes carotid pulse. And of course, carotid, but not radial pulse must be used because this is short distance. But for radial pulse, long distance, and you can't understand where is first, where is second. Okay, what else we should examine? Examiner should take time in each area before continuing on the next area. So we should carefully examine each area and understand what happened in each point of auscultation. You should listen several cardiac cycles at each position to be certain of the observations made with include respiratory effects. In each position, you should ask patient breathing. You should examine and listen each position when patient breathe in, when patient breathe out, and what happened with heart sounds. Again, goals of auscultation. What we should describe examining our patient. First, we should describe intensity of S1 in all areas, intensity of S2 in all areas. So we should identify or describe intensity of S1 and S2 in all points of auscultation. Then you should characterize any systolic sounds and characterization of any diastolic sounds. First of all, in each point of auscultation, you should answer which sound is louder, first or second. What does it mean first sound louder? You should hear something like this. So you can hear this first sound louder than second sound. What does it mean second sound louder? You can hear something like this. So, question. And normally, which heart sound should be louder, first or second? Answer is very simple. It depends on which point you examine. Which points you examine. Now just imagine, now we are in Zoom, but before you listen to lectures in big lecture halls, And just imagine, in this big lecture hall, two doors, one near the lecture and second door near the faraway part of the lecture hall. If I ask two students to open and close two doors with the same intensity, which door create more sound, more noise? Answer is simple. It depends where you are. For lecture, the door which is nearby sound louder. But for students who are far away, the door which is closer to them sound louder. It means that it depends where you are, which place you examine. And again, let's remember heart sounds. I told you already. First heart sound, this is closure of mitral valve and tricuspid valve. Second heart sound, this is closure of semilunar valves, pulmonic and aortic. Remember, points of correspondence. If we put phoneindoscope into under the first point of auscultation, first point, which sound should be louder? First point, this is mitral valve. Mitral valve produce first heart sound. It means that first point, first heart sound should be louder than second, very easily. Then you move to second point of auscultation, aortic valve. Aortic valve produce second heart sound. If aortic valve produce second heart sound, it means that in second point of auscultation, second sound will be louder. Next, pulmonic valve also produce second sound louder than first. Tricuspid valve. Tricuspid valve produce first heart sound. It means that first heart sound should be louder. You may ask, and what we'll find in Erb's point between first and second heart, between aorta and mitral valve? Sounds will be more or less equal. So very easy to remember. Again, you shouldn't learn by heart. You should understand why it's happened. And in this case, you can easily answer all such questions. Again, first heart sounds is loudest at the cardiac apex, and the second heart sound loudest at the base of the heart. Now again, I'll try to explain you why. Cardiac apex, this is near cardiac apex, we have mitral valve, we have tricuspid valve, and base of the heart on the top where is pulmonic and aortic valve. Second heart sound louder. Okay, now we should start talking about murmurs. So normally, examining the heart, you can find only sounds. Murmurs, this is something additional, some additional noise in the heart. We know as murmurs. What is murmurs? Again, something vibrate in the heart. What may vibrate in the heart more? Murmurs produced when there is turbulent energy in the walls of the heart and blood vessels. Obstruction to flow or flowing from narrow to large diameter vessel produce turbulence. Turbulence set up eddies that strike the walls to produce vibrations that the examiner recognizes as murmurs. Okay, let me try to explain more easily. You know from physics that there are two ways of liquid flow. Yeah? We talk about water, blood, liquids. We have laminar flow and turbulent flow. Laminar flow and turbulent flow. Now just imagine if you're on the bank of the Volga River, which is actually very dangerous, you know. Can you hear something? Huge amount of water, but usually you can't hear this water flow. Why? Because this is laminar flow. That's slow laminar flow of the water. And then imagine some small river in mountains. Small river in mountains. Amount of water thousands times less than in Volga River. But velocity of this flow is very high. As a result, these small rivers in mountains may create a lot of noise. Why? They have turbulent flow, because high velocity lead to the turbulent flow, because between water and tubes or actually shores or banks of river, we have some actually interaction which create turbulence, And again, it depends mostly on velocity of flow. High velocity, more turbulence. No, even very simple. In your kitchen, open tap a little bit. You have laminar flow and no noise. If you open completely, this is turbulent flow and a lot of noise. The same happens in the heart. So generally, if you hear murmurs, it means that this is some enlargement of velocity of blood flow. And why this enlargement may happen? Usually it's happened due to narrowing. If we have some narrowing between two chambers, for example, atrium and ventricle, if we have some narrowing of opening in valves is openings. If this opening becomes smaller, high pressure try to push blood through small opening. As a result, in this small opening, velocity increase, it creates turbulence. We can hear this as murmurs. Okay. What may create such narrowings? Actually, again, I told you that valves, this is doors. Normally, door should be open completely or closed completely. What may happen with the door? Door may be broken. Yeah? And two ways of broken may happen. First, just imagine that door is rarely broken. Half of door is absent. Yeah? As a result, this door is closed, but this door can't be closed completely. Because half of door is absent. As a result, what we have? Yes, our valve closed, but not completely. As a result, we have some opening. As a result, what will have? Blood through this opening can return, retrograde blood flow. Opening is not as big as complete open valve. As a result, we have narrowing. As a result, we have some noise production. In this case, we talk about valve incompetence. When our valve can't be closed completely. We have incompetence of actually valves. And second, what may happen? Stenosis. Stenosis, it means the door can't be open completely. Door open, but no, let me say it half. As a result, again, blood squeezed through this small opening and again may create murmurs, may create noise. We have two types of noise. We have systolic murmurs and diastolic murmurs. No, it's from the name of the murmur, it's clear that systolic murmur happened during systole, that between first and second point of auscultation. You see, first point, first sound, second half sound, and between these two sounds we have some noise. First, second, this is systolic murmur. Yeah? This is diastolic murmur, when murmur appear between second and first sound during diastole. Again, if murmur happened during systole, this is systolic murmur. Happened during diastole, this is diastolic murmur. It's clear. So, Ejection murmurs. Ejection murmur. Murmur produced by turbulence across the semilunar valves during systole, such as aortic stenosis or pulmonary stenosis. Again, remember what I told you. What is stenosis? Stenosis valve can't be opened completely. Can't be opened completely. As a result, during ejection of blood, during systole, when blood tries to squeeze through this small opening, valve can't be closed, can't be opened completely. We talk about stenosis. It creates very loud sound in case of aortic stenosis, pulmonic stenosis. No, and this is ejection murmur. Ejection murmur. Now, diamond shape described as you see, described as crescendo decrescendo, increase, decrease, increase, decrease. So we talk about ejection murmur, ejection murmur. So again, let's see this picture, easy to understand. These valves, we talk about aortic valve, pulmonic valve. Normally, these valves should be open completely during systole. Now imagine that they open a little bit. As a result, they can't be opened completely. This is narrow opening. And when blood tries to squeeze, we have very high velocity of flow in this small opening. We have turbulence flow. As a result, we have heavy or severe or loud murmur. We have loud murmur. Happens here. Again, remember, murmurs appear in valves or murmurs produced by problems of valves. And in case of stenosis, valve can't open completely of aortic valve or pulmonic valve, we have so-called ejection murmurs. Ejection happens when? In systole. That's why it's systolic murmur. It's systolic murmur. Ejection, systolic murmur. Now, these murmurs medium pitched, rare, best heard with a diaphragm of stethoscope. They based on flow. The intensity of these murmurs doesn't indicate degree of severity. You know, this is very important idea that intensity of murmur in some cases don't tell about severity of disease. Don't tell about severity of disease. Now, one example, just imagine, this is big aorta with aortic valve. Okay, we have some narrowing. It creates narrowing, it creates turbulence, it creates actually systolic ejection murmur. Then it becomes even smaller, Again, opening smaller, ejection velocity increase and sound becomes even more loud. But then it becomes even more smaller. But in this case, amount of blood which can squeeze, decrease. As amount of blood which can decrease, decrease, flow decrease, and intensity of murmur may also decrease. The condition becomes worse, but sound or intensity of murmur decrease. It does mean that we have some improvement. It does mean that we have some improvement. Regurgitant systolic murmurs. You know, the process of returning of actually blood, known as regurgitation. So, known as regurgitation. Regurgitant systolic murmurs produced by retrograde flow from high pressure area to low pressure area during systole, in case of mitral or tricuspid regurgitation. Again, let's see pictures. This is normal systole. In normal systole, AV valves, mitral and tricuspid close, and all blood ejected to aorta and pulmonic valve. But imagine what happened if we have some problem here. We have some incompetence. We have the fact that this valve can be closed completely. Valve closed, but we have some hole here. What happens in this case? Blood from ventricles, yes, go to aorta, but at the same time, blood from ventricles return from ventricle back to atrium. In this case, we talk about regurgitation. And as blood squeeze through small opening, through small hole, this regurgitation cause turbulence and cause murmur. It also will be systolic murmur, but not ejection murmur, but systolic regurgitant murmur. So term regurgitation means flow, improper, unusual way of flow due to damage of heart valves. Now, regurgitant systolic murmurs, high pitched, best heard with the diaphragm of stethoscope. No, regurgitation, incompetence, insufficiency, we use the same terms. I told you about incompetence. We can talk about insufficiency of mitral valve or regurgitation. No, in English literature, they prefer to use term regurgitation. It implies the retrograde direction of flow. Retrograde direction of flow. Diastolic murmurs. The diastolic murmurs. Now we talk about systolic murmurs. We talk about systolic murmurs, which may be due to stenosis of aortic, AV valve, aortic and pulmonary valves, semilunar valves, and incompetence or regurgitation of mitral and tricuspid valve. What may happen to diastole? In diastole, diastolic atrioventricular murmurs. Diastolic atrioventricular murmurs begin at finite time after S2 with the opening of atrioventricular valve and mitral stenosis, tricuspid stenosis, examples of such murmurs. Again, what happened? Diastolic murmurs, this is diastole. Again, remember I told you, normal blood flow from atriums to ventricles, from atriums to ventricles. AV valves open, semilunar valves closed, semilunar valves closed. What problem we may expect? Just imagine, we have mitral stenosis. Mitral stenosis, what does it mean? That valve can't open completely, can't open completely. Instead of such opening, we have 2 times smaller opening, for example. What happens in this case? Blood from atriums try to squeeze to ventricles. Yeah? Squeezing through small hole creates high velocity, turbulence, and create murmur. This murmur will happen during diastole. And that's why in stenosis of mitral valve and stenosis of tricuspid valves create diastolic murmur, diastolic murmur, diastolic AV murmur. Murmurs high-pitched, best heard with the bell of stethoscope when patient lying in the left lateral decubitus position. By the way, it's next. So we talk about mitral stenosis and tricuspid stenosis. Mitral stenosis and tricuspid stenosis. Yeah? So diastolic atrioventricular murmurs. So because the AV valve stenotic, rapid filling doesn't occur, no gradient persists throughout diastole. If the patient is in normal sinus rhythm, atrial contraction will increase the gradient at the end of diastole or presystole and increase the murmur at this time. So what we're talking about? But this murmurs, intensity of this murmur higher on at the beginning of diastole because pressure between atriums and ventricles high at the beginning of diastole. Then it's decreased. But at the end of diastole, we have active filling, contraction of atriums. Again, velocity increase, and this murmur again increase. So decrease, increase. So this is diastolic atrioventricular murmur, sensitive specific sign of atrioventricular valve stenosis. Atrioventricular valve stenosis. Diastolic semilunar murmurs. So we have another valves. We have actually semilunar valves. And in diastole, these valves should be closed. Now imagine that we have incompetence or regurgitation or insufficiency of these valves. So what does it mean? That this valve can't be closed completely, can't close completely. Result, during diastole, blood from aorta can return to ventricle, because in aorta we have pressure, ventricles in rest, delayed, relaxed, and blood can return. Returning, squeezing through small opening, creating actually again turbulence, creating murmur. That's why we may see diastolic semilunar murmurs. Diastolic semilunar murmurs begins after S2, no delay after S2 to the beginning of murmurs, no high-pitched murmurs, decrescendo in shape, best heard with the diaphragm of stethoscope when patient sitting up and leaning forward. For example, this posture, sitting up, leaning forward, good for examination of diastolic semilunar murmurs. Diastolic semilunar murmurs. Again, happened what? Regurgitation from aorta to left ventricle or from pulmonary trunk to right ventricle. Again, you see, a lot of valves, 4 valves, just again, understand please. We have 4 valves. Each valve may have 2 problems, incompetence or actually stenosis. And that's why we have 8 possible combinations of different sounds. Right? And on first hand, it's difficult to remember which murmur corresponds to which heart valve problem. But if you can understand why it's happened, you can easily answer such questions. Yeah? Okay, if you have murmurs, what you should describe? Timing in cardiac cycle, systolic, diastolic, location, where is this murmur best heard? Radiation, sometimes murmurs can radiate. For example, they heard in one point and radiate, be heard and out of the heart. Duration, intensity, pitch, quality, relation to respiration, relation to body position. All this we do, trying to understand which valve damaged, what happened with the heart. So, timing of murmurs. No, again, it's very simple. Systolic murmur means it's happened between S1 and S2. The diastolic murmur it's happened between S2 and S1. Also, we can ask, is it pansystolic, occupy the whole systole, beginning of systole, end of systole? Да? So again, a lot of questions. Not to say the truth, it's very sometimes difficult to realize, to understand. What we ask you to do just to be able to find this is murmur in the heart, something wrong. Send patient for echocardiography. In this case, they will tell you what have happened. Which area murmur best heard? What for we need to do to know this? Very simple. If murmur best heard in first point of auscultation, mitral valve, we have damaged mitral valve. If best heard second point of auscultation, aortic valve, this is aortic valve damage. So intensity of murmur corresponds underlying or corresponding valve. Yeah? That's why if you find that again, loudest murmur on the first point of auscultation, you are sure that this is mitral valve problems. Radiation, what does mean radiation? Sometimes murmurs may be heard out of the heart. Now one example, in case of aortic stenosis, noise murmur so loud that it may be heard under aorta, but at the same time it may be conducted even to carotid artery. You place your phanendoscope under carotid artery and you can hear noise, murmur. So if it's happened, sure that this is aortic stenosis. Be sure that this is aortic stenosis. Intensity of murmur. How loud is murmur? Not to say the truth, rarely we use such classification, but nevertheless, you should know that there are 6 grades of murmur. First grade, low intensity, not heard by inexperienced listener. So if I'll ask you to find such murmur, you will hear nothing because you are inexperienced listener. Grade 2, low intensity, audible by an experienced listener. Grade 3, medium intensity without thrill. 4, medium intensity with thrill. What is thrill? Thrill, this is vibrations. You place your palm on patient's chest and you feel vibrations. You know, like cat person sometimes they tell, cat person vibrations. What is it? This is low pitch component of murmur, because murmur, this is vibrations. From 20 Hz, you can hear as sounds. Lower than 20 Hz, you can feel as vibrations of the chest. That's why if you feel vibrations, this is grade 4. This is very loud murmur. Now, 5, loudest murmur audible when stethoscope placed on the chest, and loud and grade 4, even heard without phanendoscope. No, I never heard such murmurs which are audible without phanendoscope. No, it's described that it's possible. Again, what I told you, in general, intensity of murmur tell nothing about the severity of clinical state. Tell nothing about severity of clinical state. Very quiet murmur may tell about extremely severe aortic stenosis, and very loud murmur may tell about nothing. Okay, just to imagine what may happen. Pictures. This is normal mitral valve opening. This is stenosis. You see how small opening we have now, and blood should squeeze through this small opening, and of course create murmur. of course it's create murmur. Another picture, this is valve. You see, this is again edges of valve stitched. As a result, valve may be open only the small way, the small opening. This is normal opening, and this is stenotic valve. Stenotic valve. Again, you see the again cusps of semilunar valves again stitched. As a result, we have very small opening instead of this valve. This valve and this is opening due to stenosis. Now we have what? Bicuspid valve mitral, and you hear damaged. One part of one cusp completely damaged. This is whole. Of course, we'll expect regurgitation because this whole let blood return from ventricle back to atrium, creating systolic regurgitant murmur. So now I told you that it's very important to understand why it's happened, what happened, to be able to answer the questions about originating of sounds. And we can play even simple game. For example, I tell you, patient has aortic incompetence. Which murmur we expect to find out? How you should think about this? Okay, aortic incompetence. Aortic incompetence means that aortic valve can't be closed completely. Remember, when aortic valve should be closed completely? Aortic valve should be closed completely during diastole. If aortic valve can't be closed completely during diastole, it's happened what? Regurgitant blood flow. As a result, we'll find diastolic murmur. Which point? Second point. This is point of aortic valve. Just think a little bit, it can answer such question. Vice versa. We have systolic murmur best heard under first point of auscultation. The systolic murmur best heard under mitral valve. Systolic murmur best heard under mitral valve. What have happened? Let's think about this. Systolic murmur under mitral valve. Systolic murmur under mitral valve. So what should be with mitral valve during systole? During systole, mitral valve should be closed. If we can find systolic murmur during systole, it means that this valve can't close completely. It means that we have regurgitation, incompetence. Answer: incompetence, insufficiency, regurgitation of mitral valve. You see, if you understand what happened, you can easily answer what happened, which murmurs appear in which actually heart valve disease. Okay, I understand very difficult lecture, but again, try to understand, talk with your teachers. They will explain you once more, and then you will be able to answer all questions about auscultations, about heart murmurs easily. Yeah? Okay, any questions?
No, sir.
No, sir.
No, sir.
Okay, if no questions, good luck. Fortunately, last so-called days, tomorrow, day after tomorrow will be already spring weather. That's why good luck.
Thank you, sir.
Bye.
Thank you,
Thank
sir.
you, sir.